Youngish, 30s, 40s, female, with liver masses. So there's one here, one here, one here. This is an outside study, and we only have single phase. Sorry, so,
Adenomas
but it,
and bled in segment 6.
yeah, good. Yeah. So the patient was on OCP. We don't have MRs, but probably multiple adenomas, and this one. So this one got resected, and this was an unclassified adenoma. And then patient got a post-op imaging, and this is what the post-op imaging looked like. Let me do. Actually, this one is a multiphasic study for the post-op imaging. So the lesions in segment 2 is like almost not really there anymore. And some of the larger lesions that we saw anteriorly, there might be a little faint something or other there, but nothing that was as obvious as we saw in the pre-op imaging. Let me bring that up again. So just as a reminder, we saw multiple masses here. There, and then here. This looks more perfusional to me rather than a mass-like uh, enhancement like we saw in the pre-op images. And then this is the post-surgical changes. After that, kind of heterogeneous mass was resected. That was unclassified adenomas.
Were the OCPs discontinued in between because they can lead to regression?
Yes, good. Yes, and that's the teaching point here. So the patient discontinued OCPs. This is the venous phase just for completeness. And there was marked regression, and some of the lesions completely disappeared. So it was a pretty pronounced response to OCP. And so the teaching point is, that they do respond. Not all the time, but like in some cases they can. And not so much in adenomas, but we can also see vanishing tumors as well. So I think maybe Aarti talked about this before, where we see lesions like, for example, LR5 lesions in patients with cirrhosis, and they come for a follow-up without having interval treatment, and it just goes away because there's some kind of activation of the immune system that basically kills off the tumor. So that's like a known phenomenon that we can see as well. In this case, it's probably due to discontinuation of the OCP, which led to essentially like resolution of some of these larger masses. So yeah, the body
Very
does
nice.
some
Can you
pretty
tell us
remarkable
more?
things.
Can you tell us more about the unclassified adenoma? Like, does that mean it was like a mixture of multiple, or it was just like literally couldn't be classified, or do you not? I don't know. What does that mean?
So in adenomas, there's the HNF1 alpha that has fat in it. There's the inflammatory adenomas, and the beta catenin one that can transform. They're pre-malignant, and then there's unclassified, which doesn't fit into any of those three. So it's kind of like the the miscellaneous category. And so it's a minority of cases when it doesn't fall into the kind of the three main subgroups. In terms of how we treat and why we subtype, the most important thing really that it comes down to is it beta catenin expressing or not? Because with beta, if it's expressing beta catenin, it's almost always surgical because of the pre-malignant risk to transform into HCC. But otherwise, the other ones are like benign.
And so this one we're assuming is not beta catenin activated, but
Correct.
unclassified. Yep. Okay.
Yeah, it's just unclassified, so it doesn't fall into any of those three. But it's not. So clinically, is it beta catenin or not? Is what is most important. And this is not beta catenin expressing.
And as far as the rupture, actually, like somebody was asking me recently, like the HNF1 alpha, the fatty ones.
Yeah.
Those to me, I've not seen them rupture. And I was assuming that like they have like a lower risk of rupture versus the inflammatory ones, which have a higher risk of rupture. In your case, you had one that ruptured, but we can't say it was inflammatory, it was unclassified. But is that your general understanding? Like the fatty ones are a little bit safer as far as
Yeah, I mean that's the teaching, right? The inflammatory they like to rupture.
Yeah.
And then beta catenin is they're pre-malignant, and then if you're going to have one, the HNF1 alphas are probably the better ones to have.
Yeah.
and we can differentiate them with EVIST, or I mean, not totally, but the other teaching I guess we're often taught is adenomas don't take up EVIST, whereas FNH do, and that's usually when an EVIST MR is indicated. But we've learned and we had cases where adenomas do take up EVIST. But the way that EVIST is taken up is different. Like FNH is more kind of homogeneously taken up across the mass compared to adenomas, which are more heterogeneous and can be peripheral at times.
Yes. Awesome.
So this young male comes with, I mean, you guys can describe.
Seeing lots of like retroperitoneal adenopathy. There was, oh yeah, and then along the iliac vasculature. It's very infiltrative.
Mm-hmm.
So is there any history of HIV by chance?
Yes.
Okay, so I'm thinking about Kaposi's because that can be like perivascular infiltrative soft tissue. Can you show the lungs too?
Sure.
I don't really see like the flame-shaped Kaposi's kind of.
Mm-hmm. Nothing much going on in the lungs. But yeah, as you rightly said, it is a companion to the case that you showed a couple of weeks back. So diffuse Kaposi and diffuse infiltrative soft tissue around the vessels. Yes, there can be other differentials like lymphoma as well, particularly when it is slightly more well-defined. One thing that we have to know is Kaposi is the HHV8 virus is the one that leads to Kaposi sarcoma. So that affects most commonly the spindle cells and the endothelial cells of the vessels. So it's going to be like, usually found around the vessels, which means it would be present anywhere and everywhere. Most common site is skin, and then GI, I think, is the second most common site. Because it is associated with vessels, so Kaposi lymph nodes are one of the common differential for hypervascular lymph nodes, along with, say, Castleman's can also be one of the differential for hypervascular lymph nodes. So I think pretty much that's
Nice. Yeah. And GI, we often don't see it. Like they'll see it on endoscopy, but we kind of miss it on imaging.
Uh-huh.
Nice case.
Thank you.
Oh, by the way, wait, can you show the bone windows? Because they can get lucent bone lesions also.
Oh, thank you for asking. Yeah, this guy has one bone lesion. Sorry, yes, I forgot. This one.
Oh, wow. Yeah. That's probably real.
Yeah, thank you for asking.
Cool. Okay. Focus on the spleen.
Multiple lesions, but the larger one is a little bit more heterogeneous compared to the smaller ones that are more hyper intense on T2.
Okay. Yes. So there's several lesions. There's one larger one. I'll show you the in and out of phase. So this is the,
Oh,
well, this is the out of phase, and then
mm-hmm.
this is the in phase.
Like when I see those dark signal, like it makes me think about SANT.
And
Yes, exactly. But this was not a SANT. So this is arterial, this is a venous. I thought the exact same.
It doesn't have the typical T2 appearance. It has more T2 intermediate signal than I want for a SANT, but go ahead. Yeah.
Okay, so yeah, so I immediately exactly the same thing, thought SANT. It's kind of, so SANTs are usually kind of T2 dark. They have a spoke wheel fibrous central scar, and that central scar can have hemosiderin, and so it can drop signal. This lesion has a drop on the in phase, so there is hemosiderin, but it's not really in like a spoke wheel in the fibrous central scar. And then it is kind of like T2, almost brightish, not as dark as a SANT. But anyway, I would think
Biopsy.
very reasonable diagnosis. And it did get biopsied, but the thing that it ended up being, which I'll tell you in a second, but if we think it's a SANT or something else, do we think that this could be malignant? Like, why would we biopsy it?
Do you have diffusion?
Sure. There it is on. So it looks like the areas that are not with hemosiderin, let me just make sure I'm on the lowest. Oh, sorry, highest B-body. It looks like those areas, serpiginous areas around the hemosiderin probably do restrict. So anyway, it was biopsied and this was extramedullary hematopoiesis. And I'll just show you, this is the Radiopedia article, extramedullary hematopoiesis in the spleen. And there was something really interesting that I learned, which is, well, first of all, EMH, two of the most common sites of EMH are the spleen and the liver. So we often think of it as like busting out of the ribs or presacral area, but it's often actually in the liver and spleen. And we often just like don't really see it because it manifests as organomegaly. So if you just see like hepatomegaly or splenomegaly, there could be EMH infiltrating those organs. Rarely it has these more focal mass-like lesions. And then this was interesting. So more active lesions might be T2 bright and enhance, and older lesions have what my lesion had, which was kind of lower signal on T1 and T2, and then this hemosiderin deposit due to iron. So now, I mean, I guess like now that I've seen this case, I guess if I see something like this, I'll think about SANT, but also extramedullary hematopoiesis. In the end, they're both benign conditions, but I just thought it was interesting.
I still think you need biopsy.
Yeah, but because I guess like the two main things we're thinking about, these two things are both benign, but is you're thinking like we can't fully exclude a malignancy, you're saying?
Yeah.
Yeah. Yeah. I mean, especially when you have a big mass.
It's not pathognomonic. Like the imaging findings can only suggest.
Yeah. I have suggested SANTs in the past, and we've been just following them. In patients that have like renal cell carcinoma, and, you know, then they have this like big honking splenic thing with hemosiderin in it, and I'll suggest SANT, and we've just been following them and they've been stable. So
was there prior to kind of show if the growth or change?
No, but like one of them, we just prospectively followed it, but it also didn't make sense with that particular renal cell because it was like a small renal cell and this huge splenic lesion.
Yeah.
So our clinicians just decided to follow it. And now that we've been following it, it's been stable. Yeah.
So then the other smaller T2 hyperintense lesions are active then in this case?
I think so. Yeah, exactly. I think those are other sites of extramedullary hematopoiesis. And this person doesn't have like a myelofibrosis. They have iron deposition from renal failure in their liver and spleen, but they don't have like a hematologic, you know, like a myelofibrotic condition. But yeah.
So they weren't expecting that.
Yep. Yeah. Okay.
This is the patient with history of constipation. So this is the first phase, the Kegel. That's a pretty good lift. And then this is the Valsalva. Yeah, okay. And then the defecation didn't really happen despite waiting a few minutes. So there's one, and then, oh, excuse me, and there's that, and then that, and even after not really, this is it. This is as much as it'll go for like 5-10 minutes. What do you think?
I see the little anterior rectocele.
Yes.
And then it looks like the anal canal is just like not opening very much.
Yeah. Here, let me give you a little bit longer senes. Yes, it doesn't really open. She doesn't feel a sensation to go. And even after pushing, there's a little bit that she's able to evacuate, but it's still over 95% of the contrast is retained after
I mean, could there
multiple
be a
minutes.
stricture? But then you said when you said she doesn't feel, maybe there's like some kind of nerve issue.
Yeah, it's functional. It's functional. Yeah. So she she had a manometry and the balloon expulsion she was not able to expel the balloon despite 5 out of 5 strain. And then on the manometry, there was no evidence of dyssynergia. So this is a case of evacuation disorder. So evacuation disorder, there's a diagnostic criteria, at least 2 of 3 specific criteria has to be met. Abnormal balloon expulsion test, an anal rectal evacuation pattern with manometry, or impaired rectal evacuation by imaging. So they need to meet 2 of the 3, and the patient met at least 2, actually all 3, because the patient wasn't able to evacuate in the evacuation phase of the defecography, could not expel the balloon, and then had an abnormal anal rectal manometry. So evacuation disorder it causes functional constipation, and they have a hard time going. And it's actually a very difficult diagnosis to treat and manage. And so often they'll get a motility test to see kind of the colonic transit time. And in severe cases, the treatment for this is just total colectomy. So it's a pretty
Wow.
aggressive, or it's yeah.
I just Googled evacuation disorders, and there's like a few different types, like dyssynergic defecation, and then obstructed defecation syndrome, or ODS, and then rectal evacuation. Anyway, it seems like a spectrum. And then like you said, it was like the muscles or the nerves or the ability to feel the urge to go. And it sounds like a lot of different things can cause it, but the muscles and the nerves are not working together. And then there's also psychological factors or structural anatomic factors. Interesting. So it's like a big spectrum. Great. Thank you. Okay. This patient had abdominal distension.
Wow. There's something in that cystic mass kind of peripherally.
Yeah, there's something a little bit more complex over here. So we have this. What'd you say? Yes.
The female?
Mm-hmm.
Okay. Do the sag.
Mm-hmm.
Let's see where it's coming from.
But yeah, I forgot you love the sag.
I love the sag and coronals. So the uterus, it's just like a distended endometrium, or so I'm trying to see.
The uterus is back here.
Oh, there. Oh, it's getting squished. Oh, I see. So it's an adnexal
cystic
mass.
Yashant, what do you say?
Serous or mucinous cystadenoma spectrum, like adenoma,
carcinoma,
adenocarcinoma.
Yeah,
epithelial neoplasm.
Good, excellent. Okay, I'm going to show you the MR now. I'm not sure it adds that much more, but you can see that
changed.
Yeah, the loculated area moved around. It's got multiple septations. Definitely looks like a cystic epithelial neoplasm. Like you guys were saying, serous mucinous spectrum. This is the T2. This is the T1 pre. So you can see a lot of this fluid is bright. And then in the lesion itself, or like in the more complex area, there's kind of like different shades of gray, kind of leading you towards a diagnosis. I mean, this has to come out, but I guess just if you had to put your money on something, would you guess serous or mucinous? And would you guess benign or malignant?
Mucinous, because it is bright on T1.
Okay.
Benign.
Great. You guys are both right. This was a benign mucinous cystadenoma. So just a couple of points. So one, mucinous, because it has T1 hyperintensity, but also one of the other things is it has like different locules with different shades of gray. That's called the stained glass appearance. And so that's kind of one of the suggestions that it could be mucinous. Second, usually these really massive ones, like actually mucinous ones tend to be these massive ones, although serous can also be massive. But these massive ones actually tend to be benign. So even though this was 46 centimeters and I don't know, 2,400 grams, 24,000 grams, something huge, this whole thing was benign. So good for the patient. And you guys were both right.
I'm sorry, the stained glass appearance, that cystic process, what is that for? Is it just like they're just like thickened areas of
Here, I'll show you.
mucin, or what?
It's basically just areas with different levels of mucin. So MRI, they're large multilocular cysts containing fluid of various viscosity. Due to this reason, they often show variable signal intensities on T1 and T2 that give it a stained glass appearance. So the stained glass, I think, is like because there's different locules with different like shades of gray.
Yeah, so it's like thicker areas of mucin that's kind of like floating around, and maybe other like parts become stickier and then make this thing bigger.
Yeah, different amounts of mucin.
Yeah.
And then they rarely appear as unilocular cysts, whereas the big, huge unilocular cysts I've seen are often serous.
Serous. Yeah.
Yeah. Doesn't matter in the end. They're both benign, but yeah, kind of helps you hone in on it. So
cool.
And actually there was some ascites, but that was just from like sweeping third spacing. All of that was benign cytology.
This is a patient who went for a cholecystectomy for acute cholecystitis. There was no MRCP or ERCP done in the interval. They just took the patient straight to cholecystectomy. And this is the intraoperative cholangiogram. So this is a first run.
I see a biliary variant. I see the posterior duct inserting on the left duct. Yeah.
Posterior duct coming from the left. I mean the right. Yeah, the right posterior. Is it? Yeah, it's the right posterior duct, right? That arises like low insertion. Yeah.
I think. Well, what I'm seeing is the right posterior duct inserting onto the left duct. So that that one. Yep.
Yeah. Oh, okay. So the first run. So in the first run, what do you think? So there's kind of a lucency. What?
Yeah, filling defect distally.
Yeah, lucency in the lower third of the common bowel duct, and there's not really great drainage into the duodenum. And so then they go in and clear it out. Actually, I found out. They put it like it's like an antegrade scope, and they try to like clear out the filling defects. And then they get a second run, and here's a second run after they did a common bowel duct exploration, and now we have really great drainage into the duodenum. So I've observed that our surgeons are regularly doing this now, and I guess doing an intraoperative cholangiogram wasn't something that was trained or some surgeons felt comfortable doing. So that's why that led to like MRCP and then ERCP if there were CBD stones. But some of the surgeons now feel very comfortable with this, and so then they go straight to the OR, get their cholecystectomy done, do a CBD exploration, and then kind of accelerate the time to kind of getting the patient all treated and discharged. So that's kind of the workflow that we have now for patients with acute cholecystitis. But in some cases, if they're not able to get the scope in, then they'll have ERCP after the cholecystectomy to remove any residual stone that was observed intra-op during the IOC.
Nice. I always kind of wondered why they didn't do MRI before cholecystectomies. I know that would be unfeasible because there's too many patients getting cholecystectomies, but given all the like biliary variants and like possible stones, in our practice, I've seen them get MRCPs afterwards if the bili or before if the bili is up. Do you know in this case if the bilirubin was up and they just were like, we're just going to check it out intraoperatively or?
There's I think 2 surgeons and they do IOCs on all patients.
Oh, wow. Okay.
So, and if they don't see a spontaneous contrast drainage into the duodenum, then they'll do a CBD exploration. And that's what the practice is moving towards, just IOC on all patients.
Nice.
So it's really improve the process, right? Because now there's not a delay in the getting the MR, which can kind of disrupt the outpatient schedule. There's, you don't have to wait for the RCP and then, delay the surgery like by, 1 or 2 days.
Especially if
because-
they've gotten better at getting into because it is tricky to get like through the, like cystic duct into the CBD. So it sounds like they've gotten better at it.
Yep.
So this is ultrasound of the spleen from a young guy with sickle cell disease, sickle cell anemia. And what do we guys see?
Extramedullary hematopoiesis.
I will also show CT and then
I was thinking the same exact thing, Aarti.
Only because he's the master of the companion case. But if I had just seen this and sickle cell, I would have thought it was probably some benign proliferation of something. I'm not sure if I would have jumped to EMH, but. Oh yeah, I've seen this in sickle cell. Yeah, like where there's like sparing of like the severe iron deposition. And I always just assumed it was like little proliferations of like pulp that, I don't know. Oh, those were nice kidneys too. Yeah.
kidneys are dark.
Like papillary necrosis.
Iron deposition in the cortex.
Yeah, but the medulla looks like abnormally T2 hyperintense, right?
Isn't that because of relative? Yeah, I know that can happen what you're saying, but isn't that like more perceptual because the cortex has become darker?
Maybe. I'll have to look it up.
So yeah, as you rightly said, these look nodular, but at least in sickle cell, they may not be just the nodules or just extramedullary hematopoiesis. They are islands of paired splenic parenchyma. And there was this article that I saw. And these guys said in sickle cell patients, intrasplenic benign nodules corresponding to normal splenic tissue may be identified on imaging studies. So very often we presume that those are going to be EMH nodules, but they may not, at least in the case of sickle cell.
Nice. Either way, we would say benign.
Yeah.
Yashant, I think you're right about the renal hemosiderosis causing that appearance. This is just like how it looked, for example, on Radiopedia, where you get that kind of the dark cortex and then it exaggerates the medullary pyramids. I couldn't exactly find papillary necrosis on, I was looking, oh yeah, on MRI, but on CT, it would look like kind of like those amputated papillae. So I think on MRI, it might look something more like this or like these amputated calyces.
Mm-hmm.
Yeah.
So this young guy comes with young, less than 40 years guy, and there's a reason I said less than 40, I didn't say 28. So this young, less than 40 years guy comes with complaints of acute abdomen, epigastric pain. Lipase amylase is high, and what do we see here on non-contrast? Pancreas is enlarged and there's so much inflammation, so it is, and there are gallstones. So this is classic gallstone pancreatitis. Patient is admitted, and 4 days later, when the lipase is downtrending, cholecystectomy is done, and these guys did T-tube cholangiogram, which is normal. But 1 month later, the patient presents again with right upper quadrant pain. So we were thinking in terms of, is it post-cholecystectomy syndrome? One of the causes of which could be retained stone in the CBD, but they did T-tube cholangiogram, so that probably is less likely. However, the patient has all the features of obstructive jaundice, which means there is something happening to the CBD. Now, before going any further with the second set of imaging, let's review the prior imaging one more time. So that's when the patient presented the first time. acute pancreatitis, what was missed was this curvilinear hypodensity, and that shows dense shadowing. So which means there is some calcification or stones there, something like hepatolithiasis. And currently, when the patient presented again with the second episode, so the biliary dilation may not be as much, but there's some amount of faint shadowing. So there's some like sludge or stones filling in the intrahepatic biliary ducts. So could it be parasite, or could it be any other cause? So we were just like contemplating, and then MR is done, and there is filling defects in the entire CVD.
Wow.
And in one channel that we saw on ultrasound. So a lot of filling defects. And again, like, ERCP is done, it is extracted. So we see most of the right side of the system is all okay, but the left-sided ducts are dilated, and there's probably some stricture and all these filling defects. So the patient started on UDCA, which is ursodeoxycholic acid, and the patient is better. And interesting and important piece of history is patient's father had cholecystectomy at the age 28, less than 40, and sister had at the age of 30. So basically this is LPAC, which is low phospholipid associated cholelithiasis. So what happens is, like, when we wash clothes, I'm sure all of us have washed clothes. So detergent helps water to get miscible with the oil. So is the function the phospholipids do. So if the phospholipids are low in the bile, the cholesterol is going to get deposited, and cholesterol stones are going to cause biliary inflammation. And it may be seen in like very high percentage of cases. It's just that we are not aware of this entity, and maybe we are missing it. And what the diagnostic criteria are, like intrahepatic intrahepatic microlithiasis or sludge, and symptomatic gallstones in less than 40 years of age. That's why I said like the guy was not 28 but less than 40, and recurrent symptoms, which is like post-cholecystectomy syndrome. First degree relatives having gallstones constitute minor criteria, gestational cholestasis, and symptomatic relief with UDCA. So UDCA basically acts to dissolve the cholesterol into bile. So the cholesterol does not precipitate.
Wow.
That's awesome. I remember you showed this before.
Did I? Sorry.
No, I completely forgot about the syndrome. So I'm so glad you've shown it again. So I feel like there's nothing wrong with repetition, because like we forget. And now
Actually, repetition is very important for learning. So
yeah.
we're grateful for this.
Yeah.
And it might be a different case. I don't remember, but this is phenomenal.
Because every time I see intraductal stones, all I think about is RPC. Now I'm going to also think about LPAC. Cool. Thank you.
There is a case similar to this that was presented during SAR, and it was like a genetic syndrome.
Yes, Reena Jha had presented that.
I remember now, yeah.
And I was like, what? It was like the first time I had heard about it. It was a great case.
Can you, while I'm showing my case, or I don't know, like, can you tell us like how common this is? Like, do you think we're just missing it?
I don't know, like, so the literature says incidence is 25% of women under the age of 30 years with symptomatic.
That's a lot.
No. But these are people with symptomatic intrahepatic stones.
Yeah.
Of those, 25% will have LPAC. Is that what you're saying?
Oh.
There's no way it's 25% of women. That's not even like the amount of people that have gallstones.
I get your question, but I think no, I got your question, but I think I just copied this line. So maybe this is actually the incidence of LPAC only.
Okay,
Yeah.
well, you can get back
of LPAC within symptomatic patients.
Yeah.
Yes.
So they're young females.
Mm-hmm. Cool. Okay. Wait, first of all, do you guys know what sign this is? When like the left lobe of the liver is like all the way over here. I only learned this from Gane at Sabi at like one of the Jeopardy.
I know this. Beaver tail.
Yeah. This is a beaver tail liver. And like he put a picture where like this looked like the beaver and then this is like the tail. It means nothing. It basically is just like, don't, like the left lobe of the liver can be all the way over here. It doesn't really have any clinical findings. But in this,
Yashant is our radiology encyclopedia.
okay.
Why the spinal canal is so big?
Oh, there's a lot of going on in this case, but let's ignore that for now. There's probably like dural ectasia.
What is going on? It's like a wandering spleen or something.
Yeah, so that's the spleen. So like getting back to our beaver tail, like we were so focused on that, we didn't really notice the spleen wasn't there. You can actually, it's like there's a lot of hardware here, but there's a lot of vessels up here. I'll just tell you, there were a lot of varices in the wall of the stomach. And this patient actually now is having like severe GI bleeding. And then this is like the splenic vein that's twisting and twirling down here with some thrombi in it. And this is the wandering spleen. So, yeah, just a really interesting case. I'm going to bring over the article about the wandering spleen, just to review it for you. Most of the time it is seen in patients with splenomegaly. It's sort of non-specific, but it's thought that people don't have, like they're missing the ligaments that tack down the spleen. Etiologies can be like a lot of different things, including heterotaxy, lymphoproliferative disease, anytime you get splenomegaly, and you're also missing those ligaments. They can torse, so the spleen can torse and infarct. In our case, it looks like it's torsing, but not infarcted yet, but it is making thrombus, and then because of the low flow, it's backing up into the gastric, like short gastric veins, and then also causing all these gastric varices and GI bleeding. So for this patient, they ended up doing a splenectomy because the GI bleeding was like so symptomatic. So,
Wow.
yeah. Wandering spleen is often treated surgically by detorsion and splenopexy, or if necessary, a splenectomy. Well, that's a companion to your wandering kidney, wandering/floating kidney.
Yeah.
Okay, so we can see that there is a peritoneal dialysis catheter, an IUD.
What is that? It's like a stent.
IUD
Oh, it's an IUD. That's
misplaced.
oh.
Yeah, so this was an IUD that was extrauterine. It had migrated out of the uterus. This usually happens during placement, where it kind of just like dissects through the muscle. It doesn't usually cause uterine rupture because the muscle is pretty thick. And then they couldn't find the IUD later, so they placed another one. So anyway, then time goes on. We, told them about it, and then time went on. They got a kidney transplant. They
there
have
it is.
IUD in the uterus. The extrauterine IUD has now moved down into the left lower quadrant. It's affiliated with some bowel loops. And then time goes on. And it is still affiliated with bowel loops.
Wait,
looks,
but yeah, it's not just affiliated. It's like starting to get embedded into it.
Yeah, and okay, so I should have given you a time frame. So the first scan was 10 years ago. Then the next scan was 5 years ago. So 10 years ago is in the left upper quadrant, 5 years ago is down here, and then now it's still down here. So
It's like stuck to the bowel wall.
it is, yeah,
And
but
it's like in it,
asymptomatic.
in the wall. Yeah.
I mean,
I would take it out.
Well, I would say
it's waiting for a complication.
These are always really tricky to say. Is it in the bowel wall? Is it next to it? Because bowel can kind of wrap around these kind of foreign bodies.
Yeah.
But anyway, basically the patient's been asymptomatic. It's been out of the uterus for 10 years. So they're actually just leaving it alone.
Wow.
Spontaneous, migration from the uterus outside and then again into any of the discus is known. And it is at such a slow pace that, the patient will not observe or notice any signs of perforation.
Mm-hmm. Yeah. So it could be, it's like, it can be a sort of float around and not cause symptoms, I guess. Yeah. Okay. Hey, Liz, hold on one sec.
So this young female comes with pain in like suprapubic pain, and she has urinary symptoms as well. That's the uterus, right ovary, and urinary bladder. We see a inverted T-shaped structure in the bladder. No prize for guessing because we just did a similar case. Additionally, other than this T-shaped structure, we also see this curvilinear structure, which are also calcified. So this is IUD, which has gotten some calcification, and even the threads have calcified. That's how it looks on CT. And as I was talking about spontaneous migration, hope this plays, no. So this is actually, these guys are retrieving the IUD. So there's no way IUD could be put in the urinary bladder because the way the valsellum holds the cervix, that's not possible to put it into the urinary bladder via urethra. This was spontaneous migration over many, many years, and it does not leave a trace of perforation or anything. So like, similar to what Dr. Sekhar showed, that's possible that, that IUD is probably in the sigmoid colon or eventually might get into the lumen.
Wait, so it got embedded and then went through the detrusor muscles into the bladder?
Yes.
Wow.
I'm also amazed that they can retrieve it cystoscopically. It's like, how can
Oh,
you pull that
yeah.
IUD out of the urethra?
Yeah. I wish this was playing because this was like an interesting video.
But basically, they retrieved it cystoscopically.
Yes.
Wow.
That's incredible.
And a couple of other teaching points. Yes, this is rare, but like, something which I personally like is when I see CT and the patient has IUD, I always like to see uterus on sagittal because the way uterus is bent either like antiflexed or retroflexed, at times this thing can look like it is in the endometrium, but it has probably slipped down. It is in the lower uterine segment or in the cervix. So that's one teaching point if I may give. There is terminology like, when the IUD gets through the serosa, that is called perforation. But if it is not in the endometrium, but in the myometrium, that is called embedment.
Got it.
Yeah, I think that's about it for IUD.
Nice.
Okay. Yeah. Ketoacidosis, diabetes, ketoacidosis, ED, abdominal pain, vomiting, that's the usual.
Ooh. What's her
Yeah.
HCG?
What's
She's-
that?
Beta HCG.
So no, she's not pregnant. She denied pregnancy. They scanned her.
I would get a pregnancy test anyways.
Exactly. So we insisted, took a whole, they thought it was just like for the trainees, there was a concern about like some kind of cystic adenomyosis or some kind of cystic change. They didn't really think about pregnancy. So the decidual reaction, the eccentric cystic thing in the uterus. And there's a really quite a well-pronounced corpus luteum here on the right. So couldn't find anywhere in the chart of a last menstrual period. I guess there was denial to get the for the CT. So I insisted they do a pregnancy test. And so it took like we had to wait for the next day. But yeah, she was, then they also did an ultrasound the next day, 6 weeks pregnant. I think her beta, I forget what her beta was, but yes, she was urine pregnancy positive. They did an ultrasound. She was 6 weeks pregnant. So we literally diagnosed this one on a CT. And so just always think about that, and we'll review it in QA. I don't think there was anything major that she was in acutely in pain. That's fine. But I think that they were remiss not to check it because it may have been prompting her DKA as well. Just beautiful example also of the ovarian arteries. Never seen them this well. So I thought that was just a really cute case. So
Nelly, wait, she left.
yeah.
It's so funny because I thought my first thought was pregnancy and my next thought was ACUM, which is an accessory cavitated uterine malformation, which Nelly has shown multiple cases of here. And so sometimes it's funny because like we've done too much case conference. And so I'll be like, oh my God, it must be this super rare thing.
No, I think that's a question. Is it obstructed endometrial cavity in some way, whether it be genital or something else, a mass, or is there pregnancy? And then the decidual reaction was convincing, the corpus luteum was convincing, and that her I had to push it, right? And be confident, because the residents were like, no way. And I'm like, yes way. And in fact, that she'd never, in all her, there's nothing in the chart at all I could find about her LMP at least. So that was just interesting. And we trust the patient. So I think it's fair to trust the patient, but it should at least have a demarcation of her LMP, you know?
Yeah, definitely.
Do you guys routinely do urinary pregnancy tests before getting CTs, or do you just trust the patients?
We do not do a HCG before every CT. We basically, they have a questionnaire and they're willing to like sign off that they do not think they're pregnant.
Yeah, I think that's fair. I think, I mean, some degree trust the patient, but at least know something about her sexual history. Because that's another thing. Was she even sexually active? I looked for anything and I couldn't find anything. So I think you just got to follow your gut here and make sure that you've, exhausted every potential option. And it's very non-invasive to just do a urine pregnancy test first and then pursue more after that if you need to.
Yeah. And then obviously we don't like to radiate people who are pregnant, but like, it's probably like pretty low.
It's low. I mean, it's an emergency situation. You got to do what you got to do. If she was an ER patient, if they felt strongly, even if she was positive, we probably would have preferred her to get an ultrasound first. But if they were looking for API, then we may have still proceeded with this, but it's better to know. So that's why we will review it at QA. Nothing really disastrous here. It's not clear whether she's going to want the pregnancy anyway, but that's regardless of the point. You kind of want to know what you're dealing with ahead of time. It shouldn't be a surprise.
Yeah, awesome. Well, Liz, come back, bring your colleagues. We'd love to see you guys.
I'm trying to get them to come. Yeah, we have an interesting case conference earlier on Tuesdays, so I'm trying to put in everybody's calendar so that they'll come. So hopefully more of them will come. But this is great. So I've watched some of the YouTube videos, and I'm trying to share them with my trainees as much as I can. So we have some, because one of the things is like they like more interaction, and sometimes they don't have time to like gather cases or do a presentation in the middle of the day, but we can quickly go on your YouTube and see some great cases. So this is an awesome resource.
Oh, awesome. Thanks.
So that's the video from the patient we just saw. So that's the IUD, and this is all calcified. A little portion of it is slightly embedded in the muscle, which was retrieved, and these are the threads which were calcified, and they look like echogenic curvilinear structures on ultrasound.
So how do you remove it though? Surgically, or can you pull it through the urethra? Like, how are you getting that thing out?
Yeah, they went inside they had to go through the urethra.
Okay, wow, that sounds very painful. They didn't have to do any like lithotripsy or anything. They just, as well or whatever, they just
yeah, it was retrieved, yeah, in one.
Okay. Ouch.
Awesome. Thank you.